Hi, everyone. Thank you for joining us for today's webinar and e-lecture. In a moment, today's discussion moderator, GFAP Faculty Director, and Deborah R. and Edgar D. Janota Professor, Colleen Grogan, will offer a brief opening remark and an introduction of today's presenter, Assistant Professor of General Internal Medicine, Dr. Mim Ari. If you have questions during the presentation, please add them either to the Q&A pane during the presentation or save your questions and add them once the chat function is open following the presentation. A recording of today's webinar will be available on the CHAS website, or you can go to our YouTube channel, which can be found by searching for the Center for Health Administration Studies. And now Professor Grogan will introduce today's presenter.
Okay, thanks, Keith. Welcome, everybody. I wish I could see you in person, but hopefully we'll have a chance to do that in the spring when the Davis Lectureship might be meeting in a hybrid format. So I'm really excited about introducing Dr. Mim Ari. She is a general internist and addiction medicine physician at the University of Chicago, so one of our own. She has an interest in integration of substance use disorder screening and treatment into primary care, which is so incredibly important. So it's just wonderful that you're here to talk to us about your research. She is committed to improving outcomes for vulnerable patient groups who are disproportionately affected by physical, mental health, and substance use disorders. She has spearheaded a number of quality improvement efforts around safe opiate prescribing, and has, these quality improvement efforts have resulted in culture change in her academic primary care practice, which is pretty cool. She has collaborated with inpatient and emergency medicine physicians to build system-wide care pathways for patients with OUD, or opiate use disorder, including the creation of an opiate use disorder consult service, which I don't know if you'll get a chance to talk about, but that I might pick your brain about that at the end. She is also developing and studying patient-centered clinical decision support tools to care for older adults in Chicago with chronic pain, opiate use, and OUD. As a dedicated educator, she is motivated to teach concepts of OUD screening and treatment to medical students, residents, and faculty, which, given the shortages in providers to care for people with OUD, is just really incredibly needed. So I'm so glad you're with us, and so glad about the work that you do. So welcome, and with that, I'll let you take it over.
Thank you. All right, slides are showing up and my voice is there.
Yes.
All right, perfect. So thank you for the kind introduction and the opportunity to speak. As introduced, I'm Mim Ari. I'm a general internist who practices outpatient primary care and inpatient general medicine. I integrate addiction work into my practice, and I'm really excited to be here today speaking on that topic in my talk entitled Stopping Stigma, Integrating Opioid Use Disorder Care into the Work of a Generalist. I have no disclosures. There are 4 questions that I hope to answer today during the course of my talk. Why should generalists treat opioid use disorder? How should generalists be treating opioid use disorder? Where across the care continuum should we be treating opioid use disorder? And what is the effect on generalists taking on this work on stigma, or what opportunities exist there? I will be using some examples from the literature, and I'll be trying to integrate some of the data from my activities in this field at the University of Chicago into that broader framework. Question: why should generalists treat opioid use disorder? I think the first reason is that we have the skills. There are important skills that are required to care for people on chronic opioids safely and recognize and care for those with opioid use disorder. And those skills are actually central to general medicine. They're things that we are already trained to do. We're very good at screening for chronic health conditions. We do this for diabetes and hypertension and depression. We're adept at managing multiple conditions where certain things may be in the foreground and the background at different times during a therapeutic relationship. We know when patients need specialty care, and we're good at coordinating with specialists. This is part of sort of the quarterbacking role of a primary care provider. We integrate the patient's social situation into the biomedical model, which I think is especially important in addiction care. And given that opioid use disorder is a chronic disease, we're really well versed in chronic disease models of care. And this is a little bit different than the episodic models of care that are oftentimes prevalent in the specialty addiction care spectrum, where someone might like go to detox and go to rehab and go to an intensive outpatient program and then graduate and be done. It's a different type of relationship. The second reason I think we should care for patients with opioid use disorder is the reach that we have as generalists. Less than half the people with opioid use disorder currently receive any type of treatment at all. And while there are many reasons for that, access to care is one component. There are areas of the rural United States where 60% of counties lack a single provider licensed to prescribe buprenorphine, one of the FDA-approved medications to treat opioid use disorder. So even though addiction treatment access is limited, specialty addiction treatment care is limited, primary care is everywhere in all parts of the country. We have geographic reach. And the largest pool of potential opioid use disorder treatment experts is already embedded within general medicine. More than 60% of high volume buprenorphine prescribers are in primary care, while just 4.4% of those high volume prescribers are in addiction practice. And so some have termed this sort of the sleeping giant of addiction care. We have a workforce that is ready to sort of wake up and to provide care for patients with opioid use disorder. We just have to figure out sort of the right ways to awaken the sleeping giant. The third reason I think that generalists should treat opioid use disorder is that we're able. We are able to prescribe 2 of the 3 FDA-approved medications for opioid use disorder and refer out to the 3rd treatment option. And these evidence-based medications, we'll talk about this a little more, but they work. Buprenorphine and methadone reduce opioid use-related mortality by more than 50%. And there are very few other treatments that we do in primary care that can have this significant an impact on patient mortality. The final reason I think generalists should be involved in treating opioid use disorder is I think it's the right thing to do. You know, this is the moral or the ethical argument. As healthcare workers, we want to alleviate suffering and we want to improve the quality and quantity of life for all of our patients. And that includes people who use drugs. If we're able to train and to role model for the next generation what opioid use disorder care looks like from a generalist perspective, that it's a treatable health condition rather than a moral failing, I think we'll end up in a much better position in terms of our ability to treat opioid use disorder effectively. This quote here is from a recent New England Journal of Medicine editorial piece by Dr. Englander that struck me. It was looking at kind of policies and hospital-based policies for treating opioid use disorder and what needed to change to make it better. But there was a line in there that caught my ear. She said, funding for addiction consult services typically requires demonstrating financial returns on investment from avoiding readmissions and shortening hospitalizations. We believe any imperative that hospital-based substance use disorder care be justified on these grounds as deeply flawed. And I agree. Cardiology consult services and oncology consult services do not solely exist to save money. They exist to help people have a high quality and quantity of life. And it's the same thing with opioid use disorder, another chronic disease in our wheelhouse as generalists. In recognition of the central role that generalists can and should play in addiction medicine, the ACGME, which is the governing body for medical resident education for our trainees, actually added in 2022 this as a requirement, that all internal medicine graduates be required to have clinical experiences in addiction medicine as part of their training. But we have a long way to go. I mean, it's great that this is now codified, but there's work to be done. A 2019 survey of program directors, those who administer internal medicine residencies, showed that most programs had integrated didactics on OUD treatment, but fewer than 20% had started offering any clinical experiences for their residents. So how should generalists treat opioid use disorder? What are the things that we can do as generalists to treat addiction? And I'm going to talk about two things: medications for opioid use disorder, which I've already alluded to, and harm reduction. I think there's a third thing we can do, which is motivational interviewing, which is a skill set that I think we all possess as generalists, to help patients, to explore patients' goals and to help patients set goals. And this can definitely be translated into opioid use disorder care. So there are 3 FDA-approved medications to treat opioid use disorder: buprenorphine, methadone, and naltrexone. And there is decades of evidence, more so for buprenorphine and methadone, but it's there for naltrexone as well, that treatment with opioid agonists substantially reduces morbidity and mortality. It increases retention in treatment. It helps reduce overdose and overdose deaths. It's important in preventing infectious sequelae of addiction, like hepatitis C, HIV, skin and soft tissue infections. It helps reduce illicit opioid use and other criminal behavior. It increases employment, and it's been shown to improve birth outcomes. If patients take a medication-free approach, if they are detoxified off of their opioids and not started on medication, the vast majority, 90%, will resume opioid use within 1 to 2 months. And some of those patients go on to die from opioid overdose or other sequelae of their opioid use. So why do I feel that the medications are so central to treatment? This is one study that I think illustrates this. It looked, this is Dr. Sarah Wakeman's work. She published in JAMA 2 years ago, and she essentially looked at 6 different addiction treatment models and tried to see, do these different models decrease risk of overdose and decrease risk of being involved in opioid-related acute care, so like ED visits and hospitalizations. The only treatment condition that was found to do this was buprenorphine or methadone. So other things like inpatient detox, inpatient behavioral health programs, outpatient behavioral health programs, none of those had the effect on opioid overdoses. And I think this is important because while I don't want to say that behavioral health and psychosocial support aren't important, I think for some patients they are critically important. I don't think they should be a requirement for getting treatment for opioid use disorder or a reason not to offer treatment as a generalist. Like, I don't have behavioral health backup, so I'm just not going to start prescribing the medicines. The medications are the treatment. And we see this even in the nomenclature. We used to talk about medication-assisted treatment, and now we talk about medications for opioid use disorder because there's nothing assisted about the treatment. It is the treatment for opioid use disorder for many patients. I know this is not an audience of clinicians primarily, so I'm not going to talk in depth about the medications and how they work, but I think the general concept is that they allow patients to feel normal. So instead of bouncing around from feeling normal, using, feeling up, stopping use, feeling normal, using again, feeling up, but not quite as up, and coming back down, but not to normal, coming back down to kind of a place where you feel sick or having withdrawal symptoms. These medications are long acting and they allow patients to kind of stay in the normal range, in that comfort zone. And when patients feel normal, they're able to engage in activities that lead to long-term recovery, to engage in relationships, in school, in work activities, and get back to a place that's more stable. There are many patient-centered decision aids to help patients, if they're interested in a medication, decide which medication to use. This is a decision aid from California Bridge. Their email's in the bottom corner. They have a lot of really great resources that shows a comparison between buprenorphine, methadone, naltrexone, and no medication. These are all options that are available to a patient, and a generalist can talk through these options with a patient. The 2 that are boxed in red, buprenorphine and naltrexone, are treatments that can be offered in primary care. So the second thing, besides medications, how do we treat opioid use disorder, is harm reduction. So harm reduction is a movement for social justice. It's built on a belief in and a respect for the rights of people who use drugs. It addresses not just the drug use, but the conditions of use, and it recognizes that abstinence or drug-free recovery is just one of many possible goals for a patient. So how do we put that into practice as generalists? Mostly this is around making sure that when patients are using drugs, they are using them as safely as possible. So they may use only one drug at a time instead of 2 drugs that may have interactions or side effects. They may try just a small amount of a drug to see what the effect on their body is before taking a larger amount. They can use in areas where there's other people around so that somebody could call for help if needed. For patients who inject drugs, we want to make sure they're doing that in the most sterile way possible and in ways that avoid infectious risk, like rotating the veins that they're using or using their non-dominant hand so they're not always injecting in one arm. There are safe consumption facilities in Europe and in Canada where patients can use drugs in a supervised setting where there are medical personnel there on hand to respond if there's an overdose or a medical emergency. The first safe consumption facilities opened in New York about a year ago, so they are coming to the United States. And then critically important is that patients who use drugs have naloxone, which is the antidote for opioids, the reversal agent, and they have it, they know how to use it. There are people around them that have it and know how to use it, and so they're able to avert overdose deaths. These are just a few pictures about some local harm reduction resources. Chicago Recovery Alliance is an organization that's sort of the leader on this in Chicago. They drive around that large silver van and reach patients where they are at. You can go on, you can see where they're driving that day, and patients can see where they're going to be, and they give a lot of these harm reduction things to patients. There's also a new program from the Chicago Department of Public Health to give naloxone and fentanyl kits free to patients, community members, providers. And so all you need to do is email that email address that's on the screen, and they will give you the test kits. And I just took a picture of the one of them that they sent us. We give these out to patients in our primary care clinic and on our addiction consult service. So let's move on to the third question. Where should we be treating opioid use disorder? And I would say basically anywhere that generalists are found in clinical practice is a good place to be treating opioid use disorder. The first location I'm going to talk about is in inpatient settings, so kind of during acute hospitalizations for patients with opioid use disorder. This has really emerged as an opportune time to initiate treatment for addiction. It's kind of a reachable moment. Patients with addiction may not be coming into the healthcare system and attending primary care appointments regularly in the way that someone without addiction might be. And so sort of catching the patient while they're in the hospital and having an opportunity to talk to them about their addiction and treatments that are available is a real opportunity for us as healthcare workers. Substance use disorders are very common in the hospital setting. About 1 in 9 hospitalized adults has a substance use disorder, and most of those patients are not receiving treatment at the time of admission. One way that this care has been delivered is through addiction consult services, and frequently these are run by generalists, primary care doctors who work as hospitalists or in the outpatient setting who have an interest in providing this care. There's a growing body of data around addiction consult services that they improve engagement in treatment, decrease substance use, reduce rates of readmission, lead to improved trust in physicians for patients, and most importantly, they decrease mortality. So in recognition of kind of the urgent clinical need to improve care for hospitalized patients with opioid use disorder at the University of Chicago, we started an opioid use disorder consult service here in 2019. We grew quickly over our first year, and we now do about 40 to 60 new consults a month. We are consulted by teams across the institution, so that includes general medicine teams, people who are admitted, with a leg infection or with a COPD exacerbation, along with specialty medicine services, so people admitted with active cancer who are undergoing treatment, ICU teams, medical ICUs, surgical ICUs, burn ICUs, surgical teams, including our colleagues in trauma, and patients from neurology. Our team is small but mighty. We're 3 general medicine attendings and 1 nurse practitioner. We all have X waivers, so a special training to be able to prescribe buprenorphine, and we have opioid use disorder experience, and I would also say passion for this work. Our consult service does several things. Teams call us when they want an assessment of a patient who they think has opioid use disorder or who has known opioid use disorder. We recommend medications for opioid use disorder and adjunctive medicines to treat withdrawal. These medicines, as I said, can also be used for long-term treatment, so we will start these medicines, so buprenorphine and methadone. We'll guide the management of other co-occurring substance use disorders, and we help direct pain management in the context of opioid use disorder. We also talk to patients about harm reduction interventions. I mentioned we hand out the fentanyl test kits if patients are interested. We make sure naloxone is available for them at discharge, and we assist them in linking to outpatient treatment. We've built some good community partnerships with both clinics that administer buprenorphine and those that administer methadone. First 18 months of our data of our service, we have an informatics dashboard. We use that to track our consult volumes, our demographics, and our outcomes for hospitalized patients with opioid use disorder. In that first 1.5 years, we did over 850 consults on over 700 unique patients. The majority of our population reflects who is using opioids here on the south side of Chicago. So 60% of our consult volume is men, 88% are Black or African American, and they're an older population. So 70% of our consult volume is in their 50s and 60s. And this is sort of different than what you might see as sort of the face of the opioid crisis in the United States, which tends to look young and white. 70% of our patients are on Medicaid who we consult on. So, what do we do? So we start patients on medications in the hospital. The majority of our consult patients receive either buprenorphine or methadone in the hospital. These are represented by the bars in dark and lighter blue. Some patients actually receive both. Those are the orange bars. That's a technique we use when patients need acute pain management and need treatment for their opioid use disorder. And then at discharge, most patients leave with naloxone, as I mentioned before. If they're started on buprenorphine, they leave with a prescription for buprenorphine to last them until they get to their outpatient buprenorphine provider. And we can't prescribe methadone yet at discharge due to some federal regulations, but we've continued to work on innovative linkage to care models that allow a patient to start methadone in the hospital and then continue that methadone treatment at a methadone treatment program without interruption after their hospitalization. Our patients have similar length of stays to patients with opioid use disorder who do not receive a consult. So us being involved in their care doesn't seem to increase their length of stay. And while we haven't seen in our data a decrease in self-directed discharges, we have seen an increase in patients who are able to access post-acute care settings like subacute rehabs or long-term acute care hospitals or acute rehabs, medical rehabs, not substance use rehabs. We have shown, similar to other addiction consult services, improvements in readmission. So patients with opioid use disorder who receive a consult have lower readmission rates than either patients with opioid use disorder who don't get a consult and even patients who don't get a consult but actually are on MOUD during their hospitalization. We've been able to show that at 30 and 90-day rates. And our OUD consult population has similar readmission rates to sort of the overall institutional population. That's a little bit about our consult service, and I'm happy to answer more questions about it during the Q&A. So where else should we be treating opioid use disorder as generalists? I think the second location is outpatient, right, in the clinic, in the primary care clinic. One important role I think we have there is making sure we're optimizing chronic opioid prescribing. Chronic opioid use and opioid use disorder are not the same thing, but there is overlap, and there are cases where patients who are started on chronic opioids develop opioid use disorder. And so the first thing that we can all do in the outpatient setting is making sure we're being appropriate stewards of outpatient opioids that are prescribed, and making sure we're screening for opioid use disorder through tools that have been developed for primary care, like the single item screener and the DAS-10. This is a USPSTF recommendation. So this is sort of the primary care, what you should be doing in primary care recommendation body. And also the CDC guidelines for chronic opioid prescribing. It's one of their 12 recommendations as well, and the one that has the most evidence behind it. The second thing that we can do in primary care is treat with the medications. I mentioned both buprenorphine and long-acting naltrexone can be prescribed out of primary care clinics. For buprenorphine naloxone, you do need to obtain a special waiver called an X waiver. It's available to physicians and advanced practice providers. It's an 8-hour training. The government sort of softened the regulations during COVID, so you can do the training, or you can just tell the DEA you plan to do the training and you can start prescribing this medication. Naltrexone doesn't require any special training to start prescribing. I put some things at the bottom, some references, but there is efficacy for this primary care model of opioid use disorder training. And then I think, you know, there's this, we're going to talk about stigma in a minute, but there's this underlying feeling sometimes that patients with opioid use disorder are difficult or challenging, or it's very hard. And I think that grows out of a sense of helplessness, like I'm not sure what I can do to help this patient. This quote is from a qualitative article that was published over 10 years ago now by Dr. Berry, who said, if you speak to any primary care clinician that has begun prescribing buprenorphine for opioid use disorder, you will invariably hear that it is among the most satisfying roles they have taken on, a good anti-burnout prescription. And I definitely feel that personally in my work. This is some of the most fulfilling work I'm able to do as a clinician. The relationships that I build with patients who I'm treating for opioid use disorder are amongst the most important to me as a physician. So if you can get sort of over the hump of starting to do this work, I think it really tends to be something that's really valuable for people. I do want to show you some kind of local tools and efforts to integrate this work into the outpatient setting. So this is a clinical decision support tool around opioids that was developed as part of the primary care group's behavioral health integration program, and helps to guide providers who may not be doing addiction care themselves yet. Like, what do you do if you suspect opioid misuse? If you suspect a patient's diverting the opioids you're prescribing, or if you suspect opioid use disorder, or if you need to taper a patient because they're having side effects of the medication. And really helps to give providers some support to sort of walk through what to do. Dr. Grogan mentioned ICOPE in my introduction, and I wanted to spend a few minutes talking about that. I am one of the primary investigators on ICOPE, which is an ARC-funded effort to improve management of chronic pain, opioid use, and opioid use disorder among Chicago's older adults. What we do is we collect patient information in the form of a patient questionnaire about their pain, but also about their opioid use, and we screen them for opioid use disorder as part of that process. We feed forward that information to clinicians who then are able to use a embedded clinical decision support tool called the Smart Set in Epic to help manage opioid use disorder. And so I just did a screenshot of the opioid use disorder part of that clinical decision support tool. So giving providers kind of at your fingertips ability to do this. This is a partnership between University of Chicago and Access. So we are rolling out this project to 35 clinics across Chicago, and we'll start evaluating its impacts in the next year. Another way that locally we've been able to support kind of the outpatient management of opioid use disorder for generalists is through ECHO Chicago courses. So ECHO is a virtual platform that engages providers, kind of a hub and spoke model, and gives them specialty or more advanced training. ICOPE ECHO Chicago has been running an opioid use disorder ICOPE series for over 5 years now. And as part of our ICOPE work, we were able to start a pain management and opioid use disorder in older adult series, which we did 5 times over the last year. We were able to show in our work that this type of kind of 8 sessions, virtual sessions, mix of didactics and participants bringing in cases to discuss with experts, increased self-efficacy across our competencies. And one of the things that participants felt most the highest increase in self-efficacy for was using medications for opioid use disorder in older adults. So there are ways to sort of get this education to the people who are in that outpatient setting, this generalist workforce who's that sleeping giant. We can wake them up and have them start doing this. So I'm going to move to our 4th question, which is, what is the effect of this work on stigma? And I know that I'm not the only one in this lecture series this fall who is using stigma in their title. So I'm guessing this crowd is pretty well versed in stigma, but I'll try to talk about it a little bit in the context of healthcare settings and what the generalist who's interested in opioid use disorder can do to help stop stigma. So stigma is pervasive towards people who use drugs. It occurs at many levels. It occurs obviously outside of healthcare. In a 2017 national survey, only 20% of Americans reported viewing a person with opioid use disorder as deserving, as opposed to worthless. A WHO study of 18 stigmatized conditions, drug use disorders was the top of that list. It was number 1. And this is important. I think you guys are the experts in this topic, but public opinion, public opinion and these stigmatizing attitudes correlate then with lower support for evidence-based public health policies like expanding pharmacologic treatment for opioid use disorder or establishing safe consumption sites. We also see stigma in both settings I've talked about, outpatient, inpatient. In the outpatient setting, we've seen patients turned away if they have an opioid use disorder, or if they're on chronic opioids, someone says, well, I'm just not going to take you into my practice, or I'm not going to prescribe opioids for you because I think they're too dangerous. And we see it in the inpatient setting. I'll show you some data in a moment. We see it at the individual level, right, a patient experiencing stigma, but we also see it at some of the institutional and structural levels, and I'll talk about that as well. Let's talk about healthcare workers first. Unfortunately, many clinicians have been shown to hold negative views of people who use drugs or who have substance-related diagnoses. And this leads to, I think, 2 really negative things. People, I think, then resist delivering evidence-based treatment, and they tend to blame patients for their illness, this attribution of like personal culpability or choice to the substance use disorder. There's qualitative work that doctors fear being deceived by drug using patients, right? They think there's like active deception going on. They don't like that feeling. And because there's sort of a lack of standard approach to treating it, they tend to then avoid engaging with patients regarding complaints of pain and withdrawal if they have opioid use disorder. And patients feel this. There are feelings of stigma and that they bring to the clinical encounter. Some of that's internalized stigma that they brought into the healthcare setting. Some of it's based on experienced stigma that they've had in interactions in the past. And some of it's anticipated. It's worry that because of what they've had in the past or because of their internalized stigma that it's going to happen again. This leads to challenges. People with opioid use disorder report challenges accessing care because of their substance use disorder and variable and inadequate prescribing practices, both around treatment for opioid use disorder and around pain management with opioids. And oftentimes these negative healthcare experiences have influenced the willingness of patients to navigate services or the timeliness in presenting for care. I mentioned kind of the institutional level stigma that we see for patients with substance use disorders. Sometimes I would describe it as a punitive approach to people with addiction. Hospitals may prohibit people who use drugs from leaving their room or having visitors, in theory, so that they're not going to leave their room to use drugs or have someone come in and who's going to bring them drugs. Security guards in some places search patients' bodies, belongings, visitors as sort of a routine part of clinical care for patients with substance use disorders. And patients who do use or possess illegal illicit substances in the hospital setting are commonly administratively discharged, so stop receiving care for whatever they're hospitalized for. And, the analogy I like to think of here is, a hospital would not search the belongings of a patient with a heart attack for cigarettes and penalize them for having cigarettes in their bag. Or if a patient who had just experienced a heart attack wasn't sticking to their heart healthy diet, if they had a friend or family member bring in fast food, would we discharge them and say, you're not following our medical advice, we're going to discharge you from the hospital? And I think the answer to those questions is clearly no. So there are many ways that this plays out. This is sort of a summary of what I've talked about, but with stigma. But our actions as healthcare providers, bringing both our explicit and implicit biases to the situation, have an effect on what the patient experiences during that visit. And that tends to then flow out to patients' reaction, which can be a reduction in health-seeking behaviors, avoidance of disclosure of these stigmatized attributes about themselves, poor attitudes towards treatment, delayed treatment, and decreased likelihood to access routine care or go through with follow-up treatment plans. So what are the areas of opportunity? I've said generalists should treat opioid use disorder for many reasons, but I think an important role is because I think we have an opportunity to decrease stigma for our patients within and hopefully outside of healthcare settings. The first two bullet points there are education and exposure for peers and for the next generation of generalists, so students and residents. And I think the reason I think that education piece is so important, that I think that what drives a lot of stigma is a lack of knowledge, a lack of confidence, and a lack of self-efficacy. What can I do to help somebody? And once we're able to fill those gaps, I think then we can really improve our care and provide evidence-based, compassionate care for patients who have opioid use disorder. I think the other thing that we can do is decrease stigma through attention to our language. This is a article that out of Oregon Health Sciences University that did in-depth semi-structured interviews and focus groups as part of an evaluation of their inpatient addiction consult service, which is called Impact. And I highlight this example because I think it really shows you what just seeing generalist addiction care in action can do for those who are watching on the sidelines. So before Impact, the people who were interviewed say that hospitalization was not addressing addiction. They were seeing patients with untreated withdrawal. They were seeing patients who were doing self-directed discharges, leaving against medical advice. And because of that, they were experiencing moral distress from seeing that. After Impact, they thought that kind of addiction care had been completely reframed. Addiction was a treatable chronic illness, and they saw that patients were more engaged and communicative, and they saw that they were delivering humanizing care. I put two quotes there. One is from the title, which says, we've learned it's a medical illness, not a moral choice. I mean, that's such a powerful anti-stigma message for people who are seeing a consult service in action to walk away with. The other is there's definitely a lot of stigma around patients with use disorders that probably shows itself in subtle ways throughout their hospitalization. I think Impact does a good job keeping the patient in the center and keeping their use disorder contextualized in the greater person. Impact role models bedside interactions and how to treat people like humans. I think the other place where we can really provide education is for those who are coming up through the system. This is an example of some curricular work I've done that in part was done to address stigma. So I created a series for internal medicine residents called A Patient With. One was on the topic of opioid use disorder, one on alcohol use disorder, and one on chronic opioid prescribing. Residents could pick an empaneled patient with the condition. So a patient that they themselves took care of in primary care who had alcohol use disorder or who had opioid use disorder. And then as a facilitator, I presented material on screening, diagnosis, and treatment, but I interwove that with kind of a structured worksheet where they would apply what I was telling them to their own patient that they take care of in clinic. And at the end, I wanted them to really have a plan for action, things they were going to do the next time they saw this patient in clinic. And again, this gets to sort of my belief that if we empower people with the skills and the confidence to treat opioid use disorder, that will counteract some of the negative regard for patients. This is just an example of what that worksheet looks like for the alcohol use disorder section. So they'd be working on their computers, going back and forth from the patient's chart to the didactic material. In evaluating this curriculum, we were able to show that residents frequently encountered patients with substance use disorders, but only half felt prepared to diagnose and 20% felt prepared to treat substance use disorders. And getting at that stigma piece, 68% felt there's little I can do to help patients with substance use disorders. After the alcohol use disorder session, all residents felt prepared to diagnose and treat alcohol use disorder. And after the opioid use disorder session, all residents felt prepared to diagnose and most felt prepared to treat opioid use disorder. And probably most exciting for me is that this question, there's little I can do to help, decreased significantly. That number dropped from 68%, 5% for alcohol use disorder, and to 21% for opioid use disorder. We have also tried to start incorporating learners into our opioid use disorder consult service. We started this last academic year. We had 11 internal medicine residents rotate with us and 4 third-year medical students. It's an apprentice model, so kind of one-on-one, a learner with an attending. We did do an anonymous post-elective survey for the residents at the end of the academic year, which had a 82% response rate. So 9 residents filled it out. And we were able to show that by participating in the elective, they had increased preparedness to diagnose and treat opioid use disorder. 100% felt they had received none or too little instruction prior to the elective. But at the end, 78% felt the level of instruction was sort of just right for what they needed. And 89% felt somewhat or very prepared to diagnose and treat opioid use disorder. We were able to meet our learning objectives, which are listed there, including distinguishing between stigmatizing and non-stigmatizing terms. We also asked some questions that got at the notion of stigma. And all of our residents said that they agreed or strongly agreed that they were as comfortable talking to a person with a substance use disorder as a person without, and that they could learn from a patient with substance use disorder. They also disagreed that a patient with substance use disorder can never recover enough to have a good quality of life. And they disagreed that patients should not expect to be treated for opioid withdrawal or receive opioid analgesia to treat pain when they were in the hospital. So really making sure that we're not, these residents felt at the end that we should not be providing care that is stigmatizing to patients with opioid use disorder. While we're hoping to extend the reach of the number of people coming through our consult service, we're also hoping that people who do participate sort of act as force multipliers, right? Some of that positive role modeling that was seen at OHSU, that they can take what they know back to their residency classmates and back to their multidisciplinary care teams to help improve the level of care for patients with opioid use disorder. The final thing I'm going to talk about is using appropriate language, which is a very simple step that all of us, but generalists, can take to combat stigma. It's really important in framing substance use disorders, both for individuals and healthcare providers, that when we're talking about people who use drugs, we use person first language, right? People who use drugs, not a drug user. And we use non-biased language. And there's some examples there from Reset Stigma about what is stigmatizing language and what is preferred language. If we use the word abuse, abuser, that usually is associated with people that are morally bad in our society, right? A child abuser or someone who's physically abusive. So a person who uses drugs or a person with a substance use disorder is much more neutral. When we use words like clean, someone's urine was clean, it had no drugs in it, it's implying that a person who's actively using substances is in some way dirty, and people are not clean or dirty. And urine drug screen may be positive or negative for a certain substance. You may be familiar with the article that's referenced at the bottom, which was a trial of 516 clinicians attending a mental health conference. They read a vignette. In one vignette, the patient was called a substance abuser. In the other vignette, the patient version, it said it was a patient who has a substance use disorder. So just that substance abuser or having a substance use disorder, that was the only difference in the vignette people read. And if they read the substance abuser condition, they agreed that the person was more personally culpable and they should take punitive measures against the person. Boston Medical Center, in sort of reaction to how important language is, has instituted a hospital-wide policy, a pledge actually, around addiction. And it basically says employees should be models in the healthcare system for using language that destigmatizes addiction. So this is something that they have people sign, and it can be used in other settings as well. So there's a few take-home points from my talk today. I think generalists should treat opioid use disorder. We are part of the team that can help combat addiction. We have the skills to do this. We have the geographic reach. We have the ability, and it's the right thing to do. We can treat opioid use disorder with medications, motivational interviewing, and harm reduction, and we can do that effectively in both inpatient and outpatient settings. And generalists are really part of the solution to decrease stigma through role modeling and education for patients, for our peers, and for our trainees. So thank you so much for coming and listening. My references are in my slides here. And I am happy to now stop sharing my slides and take questions.
Okay, thanks so much. That was really interesting. Let's see if we have anything. I'm not sure if I see any, but I have questions. So I'll start us off, and then maybe people type a few things in the Q&A. I guess I do see one now. So I'll go ahead. I'll go ahead and ask the one from Harold. He asked, Harold Pollack, who you may know, does your team address inappropriate prescribing patterns such as concurrent benzo opiate prescribing?
Yes, I think we do this both sort of in the inpatient and the outpatient setting. You know, the reason for this is that if patients are taking opioids and benzodiazepines, they have an increased risk for overdose. And so we want to minimize co-prescribing of those medications as much as possible. In the outpatient setting, it's part of the CDC's chronic opioid prescribing recommendations to not prescribe those two medications. And so part of our education efforts in the outpatient setting have been around that. And in some systems, there's actually like alerts. So if you try to prescribe both of those together, you may be told like, hey, you probably shouldn't be doing that. I think though, you know, sometimes we're not prescribing the opioids, right? The patient is using drugs outside of what we're doing. And so I think it's important to educate patients that the use of those two medications can really cause increased risk for overdose. Most patients don't want to overdose. They don't want to die. And so talking to them about ways to reduce that risk is important. So that's part of the harm reduction counseling we do, is around the use of other drugs, including benzodiazepines, while the patient is using opioids.
Great, thank you for that. We have another question from Tom Hunter. He asks, can the average person carry naloxone and use it with someone experiencing an overdose? Is it okay to do this, assuming training has been provided?
Yes, absolutely. So any person can obtain naloxone. You could either get it through the Chicago Department of Public Health, or you can actually go into a pharmacy where there are standing orders in I think 49 out of 50 states to dispense naloxone without a prescription. So you do not need a prescription to access naloxone. And if you went into a pharmacist and you asked to purchase naloxone, they would provide it to you and also would provide some training around that. There's also a lot of quick YouTube videos on how to prescribe naloxone. But I think it's it's something that we should all consider having and carrying. There's data from the Boston area that sort of if you flood communities with naloxone, you may decrease some of the overdoses that would have occurred without having sort of high naloxone levels in an environment.
Yeah, that's great. We have another question from Sam Peterson. He asks, you said that medications are the treatment for OUDs, but in reality, medication without a behavioral treatment component is an incomplete model. Can you clarify the role of generalists in addressing the entire biopsychosocial approach to opiate use disorder?
Sure. So I know that that's probably one of the more controversial things that I said during this talk, that I do view medications as treatment and okay as standalone treatment. And the reason I think that is because that has been what's been shown to decrease overdose risk. I do want to clarify that I think that behavioral health treatments are oftentimes very important for patients. But what I don't want is for a generalist to say, well, I don't have behavioral health backup where I am in this county where I'm the only healthcare provider. And so because of that, I'm not going to prescribe buprenorphine naloxone because I don't have the ability to access behavioral health care. Because I think even without that, there's benefit to these medications. I think there are different primary care models where behavioral health is integrated in different ways and different flavors. So there might be a model where you see the prescribing doctor for 15 or 20 minutes, and everyone does that, and then you do some type of group therapy in the outpatient-based setting. You may have models where you do individual therapy at the same time or co-located with where you do primary care. I think also generalists who really care about this work do some of their own, seek out opportunities to learn more about sort of psychosocial approaches to treating opioid use disorder and integrating that into the care. For the patients I treat as an outpatient, I would say that probably 80% of them are involved in some type of psychologic treatment. Some of that is seeing somebody individually. Some of that is seeing someone with the group. Some is peer support, like attending an organization like Narcotics Anonymous or Smart Recovery.
Thanks for that. So I'll chime in here. So it's my understanding, like the Association for Addiction Medicine, has come out with the ASAM guidelines for OUD, and I think you're right that the evidence does suggest that if your outcome is reducing overdose, then MOUD alone is sufficient. But if your outcome changes, right, to think about different modes of recovery, then back to Sam Peterson's question, you might want to think about the whole step down process, right, from inpatient detoxification to, residential care if indicated, then to intensive outpatient, et cetera, right, the whole step down process. Yeah. So it seems to me that getting patients through the step down process to move towards recovery, a kind of a more holistic notion of what recovery might look like, demands that generalist work in a multidisciplinary team. And I didn't hear you talk much about that. So I was just curious what you were thinking about in terms of some of your different programs you've started, if you are incorporating sort of trying to help generalists think about, creating multidisciplinary teams.
Absolutely. I mean, I think that the team aspect to this care is really important. Our addiction consult service is essentially self-funded. We said we want to do this and we're passionate about it, and let's start, even though we didn't have external funding. And so we are funded by essentially the consults we do generate revenue, and that flows back to our divisions. And so it buys out some of our clinical time. But there are models that are more fully funded here, even in the city. So Up at Rush, their addiction consult service has a full-time pharmacist who rounds with them. It has an addiction medicine certified person. I think they're both psychiatrists that they have right now. They have a full-time social worker or patient navigator who's part of that team. And also, I'm not sure they do, but many other addiction consult services have people in recovery who are part of the team and round with the team and talk with the patients. And I think all of that is important to improve the success of these efforts. But I will say I don't necessarily think that they have to be in place to start doing this work. In building our community partnerships, we have tried to access some of those services. So one of the people we partner with is HRDI, which is a methadone treatment program. And we had a small grant from the Illinois Public Health Institute to try to improve our linkage to care. And what they decided to do with that money was to hire a person in recovery who could do outreach back to our patients who were hospitalized. So they weren't a part of our team, but they were part of our sort of broader team. We do have support from the social workers at the University of Chicago and access our social work and patient navigator colleagues through the primary teams that are taking care of those patients. So I do think that that is important, and I don't leave them out to discount their role. I talk about our role to say that we can be people who are part of the team to care for opioid use disorder.
Yeah, absolutely. Just as you said, with, it just seems the language around this seems like that would, I just wonder what you think about the language around thinking about just clinical care, and like of course generalists should be getting involved in care for persons with OUD and with SUD more generally, and if all they can do is provide MOUD, that's still incredibly important. But it's sort of like you wouldn't want to stop there, it seems like.
I agree, and I think I do have patients though that sort of aren't ready to engage in other parts of the care spectrum, don't want to talk to somebody, don't want to see somebody, and I don't tell them they can't continue to receive MOUD because of that. If they're not willing to go to NA, or if they're not willing to see a therapist, I don't say, well, that's a condition of me continuing to treat you. I did, I did hear something different though, but in your first question that I wanted to go back to, which was sort of this ASAM continuum of care and stepping down. I think it's a little bit interesting because it's just different than how primary care doctors see chronic diseases, which is sort of this ongoing, chronic disease management model, right? Somebody always has diabetes, and maybe the diabetes is well controlled or not well controlled, but we're sort of always engaged in this care for a chronic condition for diabetes. And ASAM is a little different, right? Because it sort of looks like this, right? Like that you move through things, and it's a little bit more of an episodic care model, and just something interesting to think about in terms of, if most addiction care is now going to be delivered in primary care rather than specialty care, how can we think about that conceptually?
Yeah, and I think most people in addiction medicine think of it as chronic care, chronic disease management, and not as episodic. So I wouldn't want to be perceived by anyone as making that claim. I hear what you're saying. The step down suggests that it's sort of episodic, but I think they do view it as chronic. I think you're aligned. I'll ask one more question, and then there's a couple more questions in the chat or in the Q&A. I think you mentioned that you're working with older adults that, in part because that's what you're seeing in the hospital in the inpatient consult program, but maybe also that was part of the one of the other programs you talked about. I'm forgetting the acronym. But I guess what I was curious is, I know that for older adults who have SUD, who need to go and who have an inpatient episode and need to be placed in a long-term care facility, that getting that placement, if you have some type of SUD, is very, very difficult. And so I wondered if you're, working, if you've had any experience in working on that aspect of care, since you are working with older adults.
Yes, absolutely. So many of our older adult patients and hospitalized patients generally need some level of care after leaving the hospital. And there's a lot of great work by people here. I don't know, I can't see this here, so I'm not sure if anyone's in the audience, but looking at that, like what are some of the barriers to accessing substance use disorder care in the post-acute hospital setting, and also what are some of the barriers that just having a substance use disorder may present for even accessing that care to begin with. So kind of two different things. Usually what we have found is that being on some type of medication for opioid use disorder is oftentimes a qualification for accessing that type of care. And so that's most simply done using Suboxone or buprenorphine, because we can send a patient to a subacute rehab with with 30 days of buprenorphine for them to take while they're there, and a follow-up appointment in a clinic. It's a little bit tougher with methadone. If a patient's already in a methadone clinic, then a subacute rehab has to essentially agree to take that patient to their methadone clinic. Oftentimes the methadone clinics are willing to do that on a weekly basis, but it's still like an extra step for the nursing facility. So actually getting patients on medications has seemed to be a facilitator for getting patients to the next level of care. Sometimes our job, though, is to come in and say, yes, I know it says opioid use disorder in the chart, but that was 15 years ago. This patient has not used heroin in 15 years. They are in long-term recovery, and they do not need to be on a medication. They do not need to be in treatment. They are in sustained remission. And sometimes us being involved and making that argument is helpful in getting the patient placed in the next level of care.
Yeah. Okay, so take some of these questions in the Q&A. The first one is, I might have missed it when you talked about it, but why do you prefer buprenorphine and naltrexone over methadone as treatment for OUD?
Yeah, so I do not have a preference. I think that the data is better for buprenorphine and methadone than it is for naltrexone. So I probably have a slight bias towards those two medications. But I think really the decision is a patient-centered decision, what they think will be most effective for them and most useful for them when deciding between buprenorphine and methadone. As a primary care doctor, I can only prescribe, though, buprenorphine and naltrexone in my primary care practice. So those are the only two that are options for me to directly prescribe. But there are some patients that come see me in clinic, we talk about it, they're really more interested in methadone, and then I help get them connected to a methadone clinic. And I would actually say that in our hospitalized population, here, it's, I don't know, I would maybe even say 60-40 in terms of patients being interested in methadone versus buprenorphine if they're interested in medications for opioid use disorder. And I know next week you have a speaker coming to talk specifically about methadone. And so I think maybe some of the reasons may be illuminated by their talk, but it's an interesting thing that we see in our clinical practice.
Yeah, absolutely. I mean, a number of states, when after buprenorphine sort of really came on the use really increased and the evidence was quite good. Their Medicaid programs shifted to only covering bup as opposed to bup and methadone. That's improved now lately, but we were really concerned about that because they just saw them as complete substitutes, and for a number of patients, they're not. So anyway,
including like where people can access methadone, right? Where are methadone treatment, where are methadone clinics versus buprenorphine prescribers. It's about 60-40 in our hospitalized population in terms of what they're interested in, and we support them with both and have built out pathways to support in both.
Yeah, we have more questions, but I wanted to ask one question about naltrexone. You mentioned that you don't need a waiver, if I understood you correctly, but of course you do for bup, and that's been one of the as I understand it, a significant barrier to primary care physicians prescribing bup is not getting the waiver. Now it's unclear whether it's as you said, there's many things that are restricting them from wanting to take care of patients with SUD and OUD in particular, sorry. And so given that they don't need a waiver for naltrexone and they could just prescribe that, is the waiver really such a barrier? Or, I just wondered what your view was about that. Or is it really these other things that you've really spent more time talking about?
Yeah, I mean, I guess I would say two things. Like right now, you really don't even need a waiver to prescribe buprenorphine. You basically just tell the DEA you're planning to get a waiver, and that is now sufficient. So I think this, there's a movement, XBX waiver, and I think that is gaining steam, and I think it's very possible that the waiver will go away completely. I think, though, having the ability to prescribe both for patients in primary care is important, just for the same reasons I talked about between buprenorphine and methadone, that it's just sort of patient-centered. And there are some reasons that naltrexone may not be good if patients have concurrent chronic pain. It basically blocks any opioids that they might need to treat their chronic pain or an acute pain episode. And it's harder to get patients onto naltrexone. They essentially have to be off opioids for 7 to 10 days. And that is oftentimes very, very challenging unless a patient's coming out of an acute care setting or coming out of jail to get them started on that naltrexone. So I wouldn't rely on that.
Yeah. Okay, we have another question. Thank you for the insightful presentation. Could you please comment on the roles of first responders and OUD treatment and recovery, especially in areas of limited access to primary care services?
Ooh, that's a great question. I would love to know if there are models that more directly involved first responders in treatment and recovery. Obviously they administer naloxone frequently. And I do think there are some programs that basically work with community organizations where patients, after they have had an overdose that's responded to by a first responder, get visited by like a community health worker who tries to engage the patient after that overdose episode. But I don't know, I couldn't cite that for you off the top of my head. But I think anyone who comes in contact with a patient who has opioid use disorder, who's experienced an overdose, has the opportunity to talk to patients about harm reduction and tell them about treatment options.
Yeah. Harold Pollack has another question. Addiction often brings significant challenges for loved ones and family members. How does your team help the helpers address predictable challenges that can arise from various substance use disorders?
Yes, I think it's interesting. I think some patients want their families to be involved, and some patients really don't want their families to be involved, oftentimes because the challenges, the effect of their opioid use disorder on those relationships. I see this particularly in my work with older adults, is thinking like, how do you integrate caregivers into your treatment plan? Like, especially like if an older adult patient has some type of cognitive impairment, how are they going to do a home induction for buprenorphine? Or if they have a mobility impairment, how are they going to get out of their housing to a methadone clinic every day? And so I think as much as we can engage caregivers, we try to do that on both the inpatient side and in my outpatient work, but always trying to make sure that people are okay with involving their loved ones and family members. Oftentimes patients have hid their use for long periods of time, or it has alienated them from their loved ones, and sometimes that repair process sort of can't take place at that moment of accessing treatment.
Yeah. Sam Peterson has another question as well. I just want to highlight that even though MATs or MOUDs play a hugely important role, both medically and from a harm reduction point of view, these treatments alone don't address any underlying causes of addiction. The treatment plans solely based on the medical model can be dangerous.
Yeah, I'd love to hear more on that. I mean, definitely, as a generalist, other things that I do, like some of that underlying cause of addiction, looking at other mental health conditions and screening for those, like I do with my other primary care patients, and treating, depression, anxiety when they're present and identified. there are sort of like unsafe living conditions or financial barriers that are somehow driving the addiction, you know, getting social workers involved in my clinic or in the inpatient setting. But I'd be happy to hear sort of other things that I might be missing as I'm thinking about your question.
Yeah, I don't know if Sam might want to write a little bit more, but you know, one follow-up question I had for you as well that you just touched on is just, you know, the importance of the, you know, thinking about the social determinants of health, right? And especially around substance use disorders and often sort of, you know, co-occurring concerns around lack of housing, you know, in the whole housing first movement. So I just, you know, I think that, again, to me, that points to the significance of a multidisciplinary team, that a generalist can't do all this. These are huge, huge issues, which is why it's got to be, you know, this comprehensive approach. You know,
interesting. Some of the housing first programs that are like associated with the hospital, having active substance use is considered a disqualifier for being able to enter some of those housing programs, which is, you know, which is interesting. That'll be like cited as the reason for denial. But I think even when we think about, you know, like if someone's diverting the opioids, you're prescribing them. Well, why are they diverting their opioids? Is it because they don't have money to pay for, you know, basic needs, housing, food? And, you know, oftentimes when I see that in my clinic, it's an opportunity for me to think through some of those social determinants of health that I could be doing a better job addressing. And you're completely right. Generalists cannot do that alone, but we definitely, I think, are aware and sensitive to the social determinants of health and help think about it at a patient level, you know, who on our team we can get to. But obviously, and you are all people who think about this, right? At a societal, at a policy level, what can we do to mitigate some of those effects as well?
Yeah, yeah. I know we're almost out of time. I don't see any other question. I have, I think I have one more question, maybe a couple more. But for those of you in the audience, if you want to put in your last, you have one more opportunity to throw in a question. You had mentioned some of your programs and how they were successful at sort of changing sort of physicians' sort of points of view. And I'm sorry, I'm just trying to look through my notes a little bit about sort of what some of the evidence was, and I'm not finding it. But I guess I just wondered, you know, obviously there's this, you know, it's a small sample. And so you have this question about how do you scale that up, right? And I don't know how you kind of recruited the physicians to the training, if it was voluntary or random, you know, but I just wonder what your thoughts are about kind of the selection bias there, right? That the people kind of going through the training are sort of already maybe have some biases coming in, but sort of came to the training thinking a little bit more sympathetically about the patient population. And so how you kind of think about scaling up based on some of your findings. Yeah.
Yes. I mean, I think that's a great point. Like in the educational work that I've done, you know, a resident who chooses to fill out a survey or chooses to do an OUD consult elective is probably different from a resident who doesn't choose to do that. And so, and the types of questions I'm asking are sort of the first level of, you know, outcomes that you want to see, right? People say they feel more knowledgeable, they say they feel more confident, but then you have to see what do they actually do, right? Like what do they do? And then how does it affect outcomes in primary care? And so I agree that the kind of educational level of evidence is low. I think a lot of people are trying to do this, right? 70% of residency programs have some type of didactic on opioid use disorders. They know they need to do this, but there's not a lot in the data, in the education data, of what's the best way to do this. Like, is it exposure? Is it didactics? That has not been studied in a very thorough way. So, you know, is my little curriculum I created the best way to do it, or is it this one or this one or this one? And so people are all creating lots of different things with I think the same end goal in mind, which is to give internists and generalists more experience and knowledge and confidence, but there is not there's not great data to say how we should best be doing this.
Yeah.
My personal bias is by seeing patients. I think that's how we learn as healthcare providers, is seeing patients with conditions. That tends to be very effective in learning. But I don't have any data to necessarily support that.
Yeah. So Sam and Harold are very active participants today. I love that. Sam, just following up on thinking about trauma-informed care model, a generalist alone cannot treat SUDs. So just the importance of trauma-informed care, I think, is his point.
The amount of trauma we see in our patient population is, it's huge. It's almost all, it fully feels present at every visit.
Yeah. Harold has two closing questions of time. How do you think differently about substance use disorders today than you did, say, 5 years ago? 2, many people with addiction disorders are heavy tobacco users. How can we address these more effectively? Those are 2 big questions. So I don't know if you want to just, you might be able to take 2, or you could take 1. Yeah.
How do I think differently about substance use disorders today? I think there is increasing consensus about a few things, that acute hospitalizations are a good time to reach patients, and that evidence base has really sort of exploded in the last 5 years. That I think the evidence base for medications has continued to grow over the last 5 years. And I think I have just become, working at the University of Chicago, maybe a more nuanced understanding of who the opioid crisis is affecting. That it was maybe different than when I was doing my training in Colorado, or what I was before I got more involved in this work. And I'm glad that probably many people on this call are involved in thinking deeply about the different types of communities that are affected by substance use disorders. And then, tobacco is really interesting. I would say generalists feel much more comfortable with tobacco than with other substance use disorders. That really has already sort of been adopted into our, our diseases. People feel comfortable doing the 5 A's and motivational interviewing and prescribing nicotine replacement therapy and the other medications that are used. So maybe it's an opportunity to use what we learned and did in tobacco and apply it to other substance users. Other people who use substances. And then if people have had success with one substance, cutting down or decreasing, I try to use that in my clinical interaction as a way to say, look, you quit smoking. Do you know how hard that was? What were the tools that you used to do that? What did you rely on to do that? And how can we translate that then into treating your alcohol use disorder or your opioid use disorder? And maybe the same thing is true. Once someone stops using opioids, can we now get them to quit smoking? Because we know that that is going to have a long, ability. If they're able to quit smoking, it'll have positive health ramifications for them.
Yeah, absolutely. Thank you so much. This was really, really an interesting talk, and thank you for the good work you're doing at University of Chicago. And thanks to the audience for all your good questions. All right, hopefully we'll have a chance to interact in the future, and you can, I don't know if you'll have a chance to join some of the other calls. Thanks so much. Bye, everybody.
Bye.